And it looks like we're live. Thank you, Mac. Take it away.
Good afternoon. I'm Mac Burnham, and I'm here to welcome everyone to the third Power of Purple webinar. Today, we're going to be hearing about a range of epilepsy-related topics. They will include genetics, women's issues, uh, SUDEP, and mental health. And our speakers will be doctors Danielle Andrade, Esther Bowie, Peter Carlin, and David Gold. After these talks, we'll have a question and answer session. You're invited to submit your questions into the Zoom chat box, or if you're watching on Facebook Live, you can submit your questions into the comments section. When you ask a question, please let us know which presenter you're directing the question to. As mentioned before, if you're attending through Zoom, there will also be a chance to discuss these topics further in breakout group sessions at the end. Okay, with that, I'd like to introduce our first presenter, Dr. Danielle Andrade. She is the founder and director of the Krembil Neuroscience Epilepsy Genetics Program. She's also one of our EPLINK researchers and works as a professor of medicine and neurology at the University of Toronto. Danielle?
Thank you. Thank you all for coming. I'm going to share my screen. Please let me know if you're seeing my slides. Just let me put this on the full screen mode. Okay.
We see it. Thanks, Danielle.
Thank you. I'm just going to do a quick overview of our epilepsy program at Toronto Western, and then I'll talk a little bit about genetics.
Danielle, could you get a little closer to the microphone?
Okay, is this better?
That's better, thank you.
Okay, I'll try to speak here. So we are a very large program. We have 10 doctors that are epileptologists. 3 of them are part-time, but 7 are full-time, seeing patients, doing research and teaching. We have 9 scientists, several clinical researchers. I say 1.2 epilepsy surgeons, but I feel like I have to explain. It's one surgeon that is full-time dedicated to epilepsy and another surgeon that does mainly the laser kind of surgeries. 2 neuropsychologists, Dr. David Gold, who you're going to listen from very soon, nurses, a social worker, and it's a very large group of people who work together to see our patients. We have 10 EMU beds dedicated to adults. We have 3 fellows, 5,000 patients per year, 20 graduate students, 10 postdoctoral fellows, lab technicians. So it's a very large group of people who connect the clinical reality of our patients with research and with teaching so that we can offer the best possible treatment to our patients and at the same time teach new physicians, new nurses, new psychologists so they can go on and do the best treatment possible for their patients as well. We have in our program here, it is the patient is always in the center of our care, but we have several different areas of specialization. So for instance, we have the genetics program, we have a first seizure clinic, we have the neuropsychology program, we have the neurophysiology program, which is all the EEG, the epilepsy monitoring unit, the MAG. We do clinical trials. You're going to hear from Dr. Bowie about epilepsy in women and pregnancy. We have the only ketogenic diet clinic for adults in the whole country. And of course, we do epilepsy surgery as well. We interact with a large group of people and programs because, as you know very well, patients with epilepsy have different needs. So for instance, we have a transition clinic with sick kids. We work with adult metabolic genetics, with social services, patient advocacy groups like Epilepsy Toronto, Epilepsy Peel, with psychiatrists, family doctors, OB/GYN. We have, and Dr. Bowie is one of the people leading the project ECHO, which is helping teaching the family doctors and neurologists out in the community how to better care for our patients with epilepsy. Radiology and movement disorders, we have a combined clinic of genetics and movement disorders. And on the green circle around is all the research we do, several different areas of research, and we interact with national and international groups also doing research. The EPLink, which is part of the Ontario Brain Institute, is one of our main partners in this research. And coming to the genetics, I can tell you that we live today in a genetics bubble, if you wish, with the number of genes that are associated with epilepsy. So if you look back in 1995 here, can you see my arrow when I point? Can you see the cursor here?
Don't see it.
No? Let me see if there's a way of showing. No.
Tell me what it is you're pointing to at, Danielle.
So I'm pointing to the number down in the horizontal line on the lower left quadrant of this slide, and it's the year of 1995. And on that year, the first gene associated with epilepsy was discovered, and it's this soup of letters here. And then it took more than 2 years to have the second gene discovered in 1990, almost 98, and then the third. And now this is from a paper that was published in 2011. So now 10 years later, we have way more genes than we ever thought we would find in patients with epilepsy. This is another way of looking at genetics. So in 1975, we knew the causes of epilepsy for about 1/4 of the patients. So we knew that epilepsy could be caused by trauma, stroke, cancer, infectious disease, congenital lesions, like things that the patient is born with, lack of oxygen during birth, and a few other causes. But all the rest, the 75% in the gray area here, we really didn't know what was the cause, and we call that idiopathic. Well, moving forward, 2014, we know if you look at the circle on the right side of the slide, we discovered a few more things. For instance, the autoimmune epilepsies, where the person has antibodies, their own antibodies attacking their brain. And we discover some lesions that we really couldn't see well in the imaging that we had in 1975. So of course, now we see many more things. And we know that all the rest are caused by genetic abnormalities, including the ones in this blue pie piece here, where we see focal epilepsy with MRI detectable lesions. That is also caused by genetic problems. And we have genetics underlying all other forms of epilepsy. So it is definitely a very significant component of almost all forms of epilepsy. Well, what do? We work with several patients in several different types of epilepsy. So one type of epilepsy that has a strong genetic component is a very common form of epilepsy, like juvenile myoclonic epilepsy, or people that only have generalized tonic-clonic seizures, which we call sometimes idiopathic generalized epilepsies, and temporal lobe epilepsy has a strong genetic component as well. Doesn't mean that it's inherited, and that's an important difference that we learned. So genetic doesn't necessarily mean that it's inherited. Sometimes both father and mother are completely normal. There's absolutely no one else in the family with epilepsy, but something happens in the genes once the egg and the sperm meet and they start changing their genetic material. Something happens there, and then this person has a genetic change that will lead to the epilepsy. So we work in the area of discovering new genes, and we are part of several different consortia. One of them has 10 sites in 8 different countries. Another has over 26 countries involved, and everybody sends, with consent from patients, we send our patients' DNA. We are looking at mapping the exome of 25,000 patients. We have already done 18,000 patients. And like I said, we have discovered a huge number of genes that are associated with epilepsy. Why is it important to get people from different parts of the world? Because genetic mutations are closely correlated to the background. So we know that epilepsy affects everyone, but we know that certain mutations are more common in certain regions, and that's why we want representation from all over the place. So in addition to identifying new genes, one thing that we do is to understand the natural history of the diseases. What that means. Natural history is what happens despite the fact that you're treating the patient, what is happening to the brain, to the rest of the body. So for instance, this is what happened after we discovered several genes. So for instance, children that had very severe epilepsy, often associated with intellectual disability, sometimes even with some degree of autism. In the past, they would go to sick kids and they would have the $1 million workup. But the technology at the time was not enough to show what were the mutations that were causing the patient's problem. So then they were transferred to us at Toronto Western, and we had those patients with things we knew about, like temporal lobe epilepsy, a group here. So if you look at the white triangle in this square area where you see a lot of little people, in the white part of the triangle, we have the people in the gray color who, let's say, had temporal lobe epilepsy, the people in the blue color who had epilepsy caused by tumors, and the people in the almost green color that had epilepsy, idiopathic generalized epilepsy, for instance. And then if you look at the bottom triangle of this square, you see a lot of little people in the black color, and those are the ones that had the $1 million investigation at sick kids and did not have a diagnosis. So we didn't know what they had, and they would still be called symptomatic epilepsy or cryptogenic epilepsy, or sometimes they were even called Lennox-Gastaut. And what happens is that with the genetic technology, the way it advanced, we started testing these adult patients and identified what kind of gene abnormalities they had. And then instead of having these people in the black color here, we started stratifying them into different colors representing different genes. So you have the little people in orange, green, red and purple. And then when you have this, their genetic cause identified, you can group these patients together, you can start seeing common manifestations which we could not see when we didn't have the diagnosis. So for instance, one of the things we saw is that patients with mutations in one specific gene, in addition to having seizures, they develop Parkinsonian manifestations, Parkinson's manifestations very early in life. In their early 20s, they start developing Parkinson problems. So the fact that we were able to identify the gene in this population and look at them together, like look at those that have mutation in gene A, those that had mutation in gene B, those that had mutation in gene C, we could identify new things. So for instance, like I said, one group of patients develop Parkinsonian manifestations. Another group of patients develop more hallucinations that you would expect, even schizophrenia. Another group of patients develop other kinds of motor problems with difficulties with gait, etc. So that helps us understand the patient better and treat the patient appropriately. So we can start with the medication for Parkinson, we can start with the medication for hallucinations, and have a better treatment, and overall the patient will get better. Still, all that we are talking about are treating the symptoms, right? We treat the manifestation of the genetic abnormality. What are the next things that we are looking at? So this is, don't be intimidated by the number of arrows here, but this is just to show you that we work through the AppLink and the Ontario Brain Institute. We work with doctors and patients from different places. And based on that, we can look at the DNA of these people from different places, do whole genome sequencing, and identify not only genes that cause epilepsy, but genes that are associated with certain response to medication. So right now what happens is, if we know a patient has a form of epilepsy, let's say temporal lobe epilepsy, we say medications A, B, C, and D work better for this patient, but H and F doesn't work so well for that patient. But really what we should be doing is looking at their genes to say which medications would work better for the patient. So response to medication, response to diet. Of course, we identified one gene that is associated with SUDEP, sudden unexpected death in epilepsy. And it's a gene that affects patients that don't have a syndromic epilepsy. So usually patients that have normal intellectual abilities, and really it's mainly the seizures that they have. So it's important that they know that they carry this increased risk of SUDEP. Like I said, we identified genes associated with Parkinson and other things. The next steps are precision medicine. So we want to be able to use not only the regular anti-seizure medications that come to the market every once in a while, but medications that will actually go to the root of the problem and treat the genetic problem. So to do that, there's different ways. And again, don't be intimidated by this, but just so you know, there is already today a trial of gene therapy for one severe form of epilepsy. Having said that, unfortunately, Canadian patients are not able to be part of that trial. So our next step is really to create a Ontario Genetic Epilepsy Registry. So what is that? It's a registry where we are gonna have, if patients allow and want to be part of that, every patient with a genetic epilepsy will be part of this registry. And then it's mainly for patients with have epilepsies caused by one gene only. And then why are we doing this? Because we want to start bringing clinical trials for patients that have genetic epilepsy to Toronto, to Ontario, and eventually we want to make this a national registry, so all patients in Canada will have access to that. I think it's very important when you see a patient having seizure and having problems and the medication is not working, and yes, there is a trial, but they're not enrolling Canadian patients. It's very frustrating. So it's very important that we have this registry so we can tell the groups of scientists, investigators who are creating these new forms of treatment, look, we have this number of patients here, and some of these patients are willing to be part of your trial. If you just come to Canada, you have to go through, and they have to go through a lot of regulatory obstacles to actually get the trial here. So they would only come if there were a good number of patients. So that's one of the reasons we want to create this registry, so more of our patients here will have the opportunity of being treated earlier. So I'm going to stop here. I'm happy to answer more questions later if you have, but I'll stop sharing my slides now.
Okay, thank you very much for your presentation, Danielle. Our next presenter is Dr. Esther Bowie, who is a neurologist at Toronto Western Hospital. She's also an assistant professor at the University of Toronto and co-director of the Women's Neurology Fellowship. Esther?
Thanks, Dr. Burnham. I will share my screen. And thanks, Danielle, for that panoramic view of the genetics program. Can you see my screen?
Yes, we can.
And hopefully I can have this in presentation mode. So I'll only take a few minutes, and I see some familiar names in the audience. So a shout out to everyone that I know that's here to support the epilepsy program and epilepsy in general. And thank you for Epilepsy Toronto for organizing this.
Esther, just so you know, we're seeing two screens as opposed to just one like it was before. Is
oh, okay. Let me try to see if I can.
We're seeing your presenter mode as opposed to your presentation mode, I think. There.
Is that better?
We're not seeing it now. Try sharing again. And you had it before, so whatever you did the first time worked.
Okay, we're seeing something now.
We'll go with this. We can see the next
go
one.
with this, yes.
Yeah.
Okay. So you'll have a teaser on the right and the actual presentation on the left. So thank you again for allowing me a few minutes to share with everyone the Women's in Epilepsy program. And I have the privilege of sharing this program with you and specifically highlighted and italicized the word women's, mainly to emphasize that as this program has evolved, it really has become a place that's really dedicated to providing tailored epilepsy care for women of all age throughout their lifespan. We started with the women's pregnancy clinic, but it's been very clear over the last few years that pregnancy is only one aspect, an important aspect of women's health, but there's much more work to be done, including transitional care, catamenial or menstrual related seizures, sexual dysfunction as one audience member has raised, which is a very important aspect for both men and women, as well as aging and menopause and bone health. So we have a lot of work ahead of us, but I'm excited to share with you some of the work that we've already done.
Esther, can you just try pressing on the display setting at the very top?
The very top.
In the middle, I can see it at the top of your screen, display settings. Top view. Oh. You don't see it? It's right above it.
You
don't see it. Okay.
You know what? Let me try to change this.
Don't worry about it too much. I thought I can see it on my screen, so I'm not sure. We won't worry about it.
Okay. Let me just try to find the right screen then. I'll go back to where I am, and maybe this will work this last time. Does it work?
Okay. No, now we're there we go. That worked. Perfect.
Okay.
Yay.
So I am very lucky to be surrounded by incredibly tireless and talented, tirelessly working and talented people, including our nurse specialist, Sharia Noor, our nurse practitioners, Asima Lau, Darcia Paul, our neuropharmacist, Sophia Ladak, and our social worker, Carol Lafleur. And really, we work as a team to provide two important clinics. The first is the Women's Clinic for Epilepsy Care, and it really tackles all the issues that are very specific to women. Lots of women experience seizures related to their menstrual cycle, but also there have been emerging recognition of fertility issues. There's been an explosion of fertility treatments for women with epilepsy because of the new OHIP funding structure that covers a first cycle. And so women with epilepsy are exploring these avenues that were never explored before. And a lot of our work really is preparing for pregnancy if women do choose to become pregnant, and caring for women and their families as the pregnancy progresses. It's a real privilege to see this transformation that happens to almost every single woman that goes through the clinic, from the very first few months and weeks of realizing their pregnancy to one of my most favorite moments in clinic, which is seeing a beautiful, healthy baby, a newborn baby with a understandably tired mom and dad. And then there's the emerging importance of recognizing that after pregnancy, there's more work to be done to manage both a woman as she ages, as well as her changing family structure and work structure. The specialized pregnancy clinic is really a labor of love, and I have to apologize beforehand. People who know me know that I have lots of puns, and this is the baby of our program, where women are seen throughout their 9 months of pregnancy and monitored carefully. It's really one of the few clinics in North America that see women on a monthly basis. I didn't realize that we were only one of the few clinics in North America until I started speaking to colleagues across North America. And we do monthly therapeutic drug monitoring, as well as management of seizures and drug dosing throughout pregnancy. And we monitor the postpartum care piece of this as well, anticipating important issues such as safety for both mom and baby, and mental health issues that mom may face in the context of her epilepsy. The great news is that the overwhelming majority of women are safe throughout pregnancy, and we really provide a lot of support as well as integrity to make sure that they remain safe. In fact, the numbers are 67% of women have a stable course of pregnancy, but having seen over 300 women, our clinic numbers are much more than 67%. And as we go through pregnancy and postpartum care to ensure that both mom and baby remains safe. This picture always gives a chuckle to people in the audience to recognize what often is a urban legend that men and women are very different. And I chuckle when I see this, mainly because our understanding of hormonal differences between men and women are different. And in fact, I think we understand less about men's hormonal cycling than women. And some of you in the audience may be surprised to hear this, but men do cycle. Men cycle a little bit longer than women, about 40 to 48 days cycling, whereas most women cycle in the classic 28-day cycle of their menstrual cycle. And the two real key players in this cycling component is estrogen and progesterone. And estrogen is essentially a proconvulsant. And if you're in a state that there is higher estrogen to progesterone ratio, you're in a state that you're at risk for having seizures. Whereas if you're in a higher progesterone to estrogen ratio, you are somewhat relatively protected. For those who may recognize this, two peak periods of estrogen in our cycle is ovulation, as well as perimenstrual. So the few days leading up to your menses, it's a well-recognized syndrome called perimenstrual syndrome. And there is, for some women, an associated heightened irritability, discomfort, as well as a heightened proconvulsant state. For those who have been pregnant or know the pregnancy brain, and I certainly do, having gone through 2 pregnancies, the progesterone or pregnancy brain is the brain where you lose your keys, or you lock yourself out, or you miss appointments because you've just forgotten about them. And this is when, in the first few weeks of pregnancy, your progesterone actually exponentially rises. And so this constant cycle between estrogen and progesterone is an important contributing factor to how women remain well throughout their menstrual cycle, as well as throughout their pregnancy. The Epilepsy and Pregnancy Clinic is a very special clinic. It really is the largest of its kind in Canada, and it couldn't be done without the support of many people here. It provides preconception counseling, oftentimes years before a woman considers or actively plans to conceive. We communicate with reproductive specialists as well as obstetricians to collaborate in the care for many women. And then we have monthly e-visits. And so Interestingly, COVID transformed all of our epilepsy clinics to e-visits, but we'd been long doing these e-visits with our pregnant patients because unlike the typical epilepsy visit, which is every 6 to 12 months for many people, these pregnancy visits are every month to monitor and closely manage the drug levels as well as seizures or any symptoms that come out throughout pregnancy. And then postpartum care is just as important. And oftentimes I follow women and their families up to 6 to 12 months before they transfer back to their original neurologist. One of the important aspects of our care really is that in the literature, it's been now recognized that when a woman's drug level drops in pregnancy to 65% of her pre-pregnancy level, there is a heightened risk for seizures. And so this dotted line is a important marker or boundary for us throughout pregnancy to make sure that medications are titrated up. And it's a constant dialogue between women and the clinic to ensure that whatever decision is done really reflects the values of the woman and her family. Does this work? There is evidence to support that what we do works. If you look here at Group 1 are women who are managed through specialized epilepsy and pregnancy clinics, whereas Group 2 received standard care, which is whatever the treating neurologist felt was suited. And this particular specialized epilepsy clinic saw women on a monthly basis with monthly therapeutic drug monitoring. If you look at the first top red circle, you see that the Group 1 patients had a lower percentage of seizure freedom before pregnancy, whereas Group 2 had a higher percentage of seizure freedom, meaning that Group 2 actually had a lower seizure rate. Once these women were seen in the specialized epilepsy clinic, in fact, despite being worse off, Group 1 had a lower rate of seizure deterioration. And whether that's because of drug management, of specialized epilepsy care, collaborating with obstetrical care, we're still trying to figure out, but this is a model that does impact how women experience their epilepsy care and stability throughout pregnancy. I stole this picture from Dr. Andrade with her permission, but I did appreciate how it really emphasizes the layers of work and collaboration that's needed. And this is a example of that with our women's neurology program. Epilepsy is a foundational component of this, but I couldn't have designed this program without an important partner, which is Alexandra Picula, who is my co-director of the women's neurology program. And it includes both stroke, headache, and multiple sclerosis. And really is the first ever of its kind in Canada to recognize that women's health is different from the general health when it comes to what's been studied. To give an example, basic sciences have long used the rat model to understand brain health, and it's the male rat model. And some of the early models of pain response and pain medications using an inflammatory pathway actually isn't seen in the female rat model. And so to think that some of our medications that are being designed based on our understanding of a male pain model actually was quite surprising for me to hear and learn about as well. And so we have a lot to do in terms of understanding the gender differences in brain health, particularly in epilepsy. We've been very busy these last few years, really exploding with options to collaborate and innovate. I've been working with Rory Thompson Hall on the Lullaby project, which I'll be sharing more next week on our Thursday evening session to explore whether we can intervene and improve the quality of life of women going through pregnancy by facilitating a platform for them to create a special lullaby for their unborn child throughout the course of their pregnancy. We're working on a project on stigma and whether stigma and epilepsy influences women's choices to have children in the first place. as well as working with both provincial guidelines, the Hospital for Sick Children, and national organizations to advocate and explore how better we can do for women with epilepsy. And so it's an exciting time. We're at the beginning of a very steep hill. One of the biggest accomplishments I've had in these last 5 years was to create Canada's first ever accredited Women's Neurology Fellowship. And Dr. Jeanette Moore is Canada's first ever fellow, but she's leading the way through this program to really recognize that there is an importance to look at brain health, including epilepsy, through the lens of gender. So hopefully in the next few years, we have more work to do. These are our aims and goals, but I think I've maxed out on my time to share with you all the work that we've done at the Women's Epilepsy Program. So thank you for your time.
Great, Esther, if you could stop your screen share, that would be great. Thank you. Mac Burnham, are you there? We lost Mac Burnham. Well, we'll truck along. So next up is Dr. Peter Carlin. Are you there, Dr. Carlin?
I am. Great.
We don't have your camera on yet, but maybe you could start your camera.
I'm unmuted and then start video. It doesn't seem to want to do that. For some reason.
I'm not sure why.
Co-host has asked you to start my video. Okay, here I go.
There.
It was working before. I guess it doesn't want to see my face. I don't blame it.
And if you could put your presentation to.
I will. Can you see my presentation?
We do.
Okay, I will from current slide.
And you've got your video on, but it's not working.
Okay, there you see my my video of my face. No, but
you see your presentation.
That's probably good enough. Okay, so that's to go start my video. I said hello. Is it starting? Let's see. Oh, okay. So I can start if you wish. Hello?
Go ahead, Peter. Thank you.
Okay, so I'm hi there. I'm talking about a rather difficult subject: sudden, unexpected, and usually unexplained death in epilepsy. SUDEP. I'm sure all of you've heard of it. I work at the University Health Network with Danielle Andrade is my boss, and with Esther Bowie as my neighbor. And it's a great pleasure to work in this unit. So sudden unexpected death in epilepsy is a fatal complication of epilepsy. It's defined as the sudden and unexpected, non-traumatic and non-drowning death of a person with epilepsy without any other cause, like with no toxicology or anatomical cause of death detected during the post-mortem examination. So this is a pretty frightening thing. This is something that hangs over all our heads who work in epilepsy, particularly, of course, the patients. It's not just a matter of time. That's not true. But it's the patient's nightmare. It's the family caregiver's nightmare. It's that horrible call from a spouse or parent. And it's rare, thank God, but not rare enough. So we really have to try and understand and deal with this much better than we do at present. This is, I'll just go through some of the highlights here. This is a review. It's commoner in younger adults. It's it's mostly seen with generalized tonic-clonic seizures as a precursor to the passing away with usually with respiratory depression. So most often SUDEP occurs after this type of seizure in bed during sleep, and the person is found in a prone position that's lying on their tummy. The person is often in bed alone. Typically post-ictal apnea, that cessation of breathing and slow heart rate, regress to cardiac arrest and death. And typically, actually, the breathing stops and then the heart stops. A crucial element of SUDEP is brainstem dysfunction, for which post-ictal generalized EEG suppression might be a biomarker. I'll show you a little bit of that later. but we certainly think the brainstem is where the action is for SUDEP. And there's some biochemical concomitants that people have measured, as well as genetic disorders affecting cardiac conduction and neuronal excitability. So there's many different pathways to SUDEP, according to the scientific literature. The value of nocturnal monitoring to detect seizures and post-ictal stimulation is unproven, but warrants further study. This, I think, is our big hope. Some sort of monitoring. Usually patients are less likely to have SUDEP if there's a bed partner or someone in the room or someone monitoring them, as opposed to being by themselves in bed with no one around. So, but individual risk is highest in those with treatment-resistant epilepsy who have recent and frequent generalized tonic-clonic seizures, especially during sleep. People don't take their pills. People have drug abuse problems. This is all well known. Lack of observation or monitoring in sleep, I'm repeating that, is a very important factor for reasons we don't fully understand. Here's the other problem. SUDEP can occur in patients with recent onset of epilepsy, well-controlled epilepsy, or benign epilepsy. So it's not just limited to patients with severe epilepsy who don't take their pills, who drink too much, etc. It can also be patients who actually are relatively well-controlled. And also sometimes SUDEP can occur without a preceding evident seizure. So we really have to work hard to deal with this. Now here's an editorial by Jorge Bruno, who's the head of epilepsy program in London, Ontario, and one of the leaders of EPLINC. SUDEP does not occur only in those with severe or catastrophic forms of epilepsy, or those whose seizures are difficult to control. It can occur to anybody, which I've stressed. Many of the patients in the registry died during the daytime, not just during night, despite receiving cardiopulmonary respiration. This finding indicates that perhaps the mechanism causing SUDEP are not just related to an obstruction of the airways, but more likely are cardiorespiratory, more complicated phenomena. The important take-home message from this study is that from now on, clinicians should start conversations about SUDEP with their patients and with epilepsy, their patient with epilepsy earlier rather than later. And that's a talk I've given before. I think we have to discuss SUDEP with patients with epilepsy very early on and not later on. I used to be afraid to talk about it, but now I'm afraid not to talk about it. There are many unknowns about SUDEP, and we do not talk about it with our patients. Well, now we do, likely because of the lack of knowledge about mechanism causing this condition or the risk factors associated with it. Well, there's now more knowledge, and I'll give you a little taste of it. We've worked in my laboratory at the Kreml Research Institute. We've worked on brainstem recordings and trying to see if we can see a correlate between brainstem seizure activity and respiratory and cardiac arrest. And we hypothesize that seizures starting in the brain, like in the above the brainstem, this is typical of the epilepsy we see in the cerebral cortex or in the hippocampus. And then the brain, the abnormal electrical activity becomes generalized and propagates to the whole brain, including the brainstem, which is the lower part of the brain, sitting underneath the cerebellum. And this, when the seizure activity gets into the brainstem, then the brainstem functions, including respiration and cardiac function, stop working well, and then you can get death. And we suggest that generalized cerebral activity is the precursor for seizure spread into the brainstem. So the hypothesis is seizures in the brain move into the brainstem, and that disrupts the respiratory and cardiac systems. So we actually have published some papers on this. This is the most recent one, where we stuck electrodes measuring epileptic activity in the cortex, hippocampus, and in the brainstem. So this is a complicated slide. Don't worry about it. I'll just show you a few things. Here we're recording electrical activity in the HC, the hippocampus, and this is where we injected a convulsant to make seizures. And this is a recording in the cortex, which is the part that's most accessible to our scalp EEG, which I'm sure all of you patients with epilepsy have had. And this is a recording from the brainstem. And this is actually an awake behaving animal. And you can see that we're measuring the heart rate and the respiratory rate, EKG, RR. And the point I want to make here is, if anything, the respiratory rate speeds up a little bit. That's pull up of the bottom here. Can you see my cursor, by the way?
Yes.
Okay, great. And that's it. Now, if you get seizures now getting into the brainstem, then you actually get disruption of the respiratory rate becomes blocked and the cardiac rate. So they both become quite abnormal and slowed. And then we show that when the animals passed away, the respiration stopped. This is RR at the bottom, stopped before the EKG. Okay, so that's a great animal model to understand and try and treat. So that's one thing, and we're working on this animal model to understand in greater depth what are the various factors involved in the brainstem and causing respiratory arrest and cardiac arrest in the context of epilepsy. The other thing that we're doing, this is in collaboration with Dr. Berj Bardakian, who's a mathematician engineer at the engineering department at U of T, is looking for a biomarker for SUDEP. So is there something in the EEGs that we can see in patients who have passed away from epilepsy? We have the EEGs from their admissions to the epilepsy monitoring unit, in addition to other EEGs, compared to those patients who did not later pass away, at least to our knowledge, we have detailed EEG data from their admissions to the epilepsy monitoring unit. So this now talks to the modern interpretation of EEG, to the electroencephalographers, the EEGer. We look at the up to about 30 cycles per second, that's hertz, and they just look at it. But now with digitization of EEG, you can do much, much more with those data, including looking at higher frequencies. And one of the major hallmarks of epilepsy is on a slow frequency, you get very fast spikes, or ripples they're called. Here's another example here. And you can compute this and put it onto a graph, and you can see here's the slow frequencies versus the high frequencies. And the point here is that you can see this biomarker of modulated high frequency amplitude with low frequencies. Okay, don't worry about you don't understand it all. It's took me a long time to figure it out too. This I want to show you here though. Here's the biomarker. We see here in a patient who's having a seizure, that during the seizure, and these biomarkers, you can see that the here. You can see that this biomarker comes out, this modulation comes out during the actual seizure, and it comes and it goes. And this is another example of the biomarker coming and going. And the last point I want to make is this is the biomarker from an intracranial recording and also from a scalp recording of a patient who unfortunately passed with SUDEP well after the admission to the epilepsy monitoring unit. And the big point I want to make is that the variability of this biomarker was much, much less. So here you can see it throughout various aspects of the EEG. So instead of getting this coming and going, this variability, you get this biomarker persisting. And this we found both in recordings from inside the brain and from outside the brain. So that is a version of the biomarker that we think can help us assess those patients at greatest risk for SUDEP versus those that are much less risk for SUDEP. And the big key is the variability of this biomarker. It's known that if you have a very invariable heart rate, that's also a bad predictor for heart disease. And we are working on the scalp EEG because, of course, very few patients get electrodes stuck into their brain to validate this biomarker. Okay, that's basically the end. So this raises a lot of questions, some of them ethical, of course. First of all, how reliable is this EEG biomarker? Do we as doctors or you as patients, do we want to really know about this? And how do we feel if we have this biomarker, and what are we going to do about it? This hasn't been worked out in my mind anyways. Now, this biomarker, when does it happen? Is it present from birth, or does it occur during the development or evolution of seizures? This is a fascinating question that requires much more research. What about the genetic correlations? Dr. Andrade already mentioned that there are some genetic correlations to SUDEP, and this is certainly well known. What's the underlying pathophysiology, including the relationship to brainstem seizures? We are working on this in my laboratory. It's a fascinating, complex subject. And can we administer drugs or do techniques to prevent the animals having SUDEP and ultimately humans? So can it be reversed? Now, here's the final thing is, can home seizure monitoring devices, including comfortable wireless EEG headsets that people can wear overnight, used to predict and prevent or warn of impending seizures, or even trigger a stimulus that could prevent SUDEP? I think this is possible, and people, including us, are working on this, a very exciting possibility. So at the end of another lecture, we're arguing about whether we should tell our patients about SUDEP or not. I'd be very interested in your opinions, but we think we should tell patients who have epilepsy, the definite diagnosis of epilepsy, that SUDEP is part of the risk. It may be a small part, but it's there. The biomarker is being discovered, which will alert clinicians and patients to those at high risk for developing SUDEP. The pathogenesis is becoming more clear, and in the near, hopefully, future, comfortable home monitoring headsets will be worn at night with software to predict, warn, intervene, and prevent deadly post-ictal apnea and cardiac arrest. Thank you.
Thank you, Peter. I must apologize to everyone. I lost my signal for a while and had to leave and rejoin the meeting. Our next and last speaker is Dr. David Gold, who is a staff neuropsychologist at the Toronto Western Hospital. He's also an assistant professor in the Department of Psychiatry at the University of Toronto and maintains a small private practice. Dr. Gold?
Okay, hello everyone. I'm here to talk to you a little bit about mood and epilepsy for Purple Day 2021. And so just to introduce myself, my name's David Gold. I'm a neuropsychologist. So that means I'm interested in how people's thinking affects their behavior, but also how their feeling affects their behavior. So I'll talk to you a little bit about that. I work at Toronto Western Hospital, and I'm also an assistant professor of psychiatry at the University of Toronto. And so just to give you a little bit about myself and some of the things we see a lot of individuals who have epilepsy here at the hospital. And so when it comes to how we're feeling or how we're doing, there's a lot of factors in epilepsy that can contribute to people not feeling great. And when I say not feeling great, I refer to things like anxiety or depression. And so with some of our patients, they face things like epilepsy surgery, they face things like lesions in their brain, and they also face things like seizures and the medications to treat seizures and other factors. And so I put up this slide just to talk to you a little bit about how there are a lot of different ways that individuals living with epilepsy can experience difficulty with their mood. And so what we know about these individuals is that they're more likely to have things like anxiety or feeling more stressed out or worried or panicky. And so about 22.8% of people living with epilepsy will have that type of challenge with anxiety. And that's relative to 5.6% of people in the general population. And so this study was done before COVID, and things might be even more problematic. But I just wanted to give you a sense that about 1 in 4 people that live with epilepsy will also have an anxiety issue. Another thing that comes up is depression or feeling down, periods of feeling low mood and sadness, not enjoying things that you like to do. And so relative to the population, once again, that they are much more likely to have issues with depression than the rest of the population. And so some of the factors that contribute to this are having seizures that make people not feel great, but they're also uncontrollable events, and the way they make us feel with the medication can also be troubling. And also another factor is all sorts of lifestyle related things that come up with epilepsy. So we know that anxiety and depression are certainly things that impact individuals with epilepsy. And so just to give you a little bit of an introduction to what I do, is as a psychologist, I'm interested in talking to people about how they're doing with their thoughts and their feelings and their behavior. And so, an example that I like to talk about is the example of COVID. And so, we have particular thoughts about COVID, and that leads to particular feelings about COVID. And then we have COVID related behaviors. So, if we're feeling the right amount of fear for getting COVID, well, then maybe one thing we do is we change our behaviors and we're good about wearing our masks and we use hand sanitizer and we're careful in that regard. And that influences our thoughts about COVID, which is it's a virus and a disease. And so we should probably be quite cautious in terms of our activities. And so we can see how our thoughts and feelings influence our behaviors and the other way around as well. And so sometimes we might think about things in ways that impact our feelings or behaviors that aren't necessarily helpful. So, an example of a thought could be, people don't like me, and that could make us feel badly, and that could lead us to the behavior of being more isolated. And so, one of the areas that we think about are how can we interrupt this cycle of either feelings, behaviors, or thoughts so that someone can feel better? And so, an example could be if I have the thought that um, people think that I talk too slowly, and maybe that leads me to feel sad about myself, and then I don't volunteer to give talks anymore. So maybe we could challenge the thought that I talk too slowly by looking at the evidence. Maybe we ask some people, and then when we take a balanced look at that and see that maybe it's not the case that I talk too slowly, maybe I talk at a normal rate, well, that makes me feel a little bit more neutral and a little more positive, and that leads me to volunteer for giving talks in the future. So I know that was a silly little example about me, but I want to give you just a little bit of an influence or a little bit of a discussion about how the way we think about the world influences how we feel and how we behave. And so that's an example of a type of cognitive behavioral therapy intervention. And so if we focused on how we feel or how we behave or how we think, we can challenge certain types of thinking to look at the evidence to say, what evidence do I have to support my particular thought? And if the answer is there's not a lot of evidence to support that, then maybe we're thinking in a way that's not necessarily helpful. So sometimes you may see this in a friend who's particularly hard on themselves or doesn't talk to themselves nicely. And so one thing we do with cognitive behavioral therapy for anxiety or depression is think, can I talk to myself in a way that makes me feel less down or anxious? And usually that can lead to people feeling a little bit different. So I'm happy to answer any more questions about that topic, or to talk to people more on March 19th. Thank you. Bye-bye.
Okay, thank you very much, David. Um, we've just been talking to Mackenzie. We're running over time-wise a little bit today, and so she suggested that we perhaps do one question per doctor, and then hold the rest for our breakout rooms. First question would really be for Danielle. Danielle, people want to know about how they would get gene counseling or how they would get genetic testing. It doesn't seem to be available everywhere. What would you suggest?
Okay, so child neurologists are getting.
Danielle, can you lean in a bit more? We're having a hard time hearing. Thank you.
Is it better now?
Yes, better. Thank you.
Okay, so the child neurologists, they are getting more used to ordering genetic testing. And if you bring this up to your child neurologist, it's more likely that they will request, given that your epilepsy is within that group of epilepsies that are likely to have a genetic basis. The adult neurologists are a little more, it's not part of their training. So part of our mission is to get more adult neurologists to incorporate genetic testing as part of the patient's diagnosis and treatment. Having said all this, there are clear regulations set up by the Ministry of Health on what are the prerequisites to allow for genetic testing. So the ministry will pay for the genetic test as long as certain things are present. So that depends a bit on the type of epilepsy, but also if you're not in an academic center where the physicians are also professors in the university, or if you're not in one of the epilepsy centers of excellence, then those neurologists might need to have had some kind of training, which is being offered by the Project ECHO. But just so you know, it's not very difficult to get tested if you fill out the prerequisites for that. But sometimes you might need to ask your doctor.
Thank you. Next question is for Dr. Bowie. Esther, people wonder about whether the anti-epileptic drugs can cause a loss of libido in people who take them.
That's a great question, and kudos to the person who asked that question. It's something that we don't speak enough about with our own neurologists for both men and women. What's interesting is that there are gender differences with regards to sexual dysfunction, and not just the medication, but also epilepsy in of itself. And what's interesting is that for some women, the medication and their history of epilepsy may actually impact a lack of interest or sexual desire. And then it's actually achieving orgasm. And so there are not just important aspects to address, but also specific to the gender of the patient. What's also very interesting is that medications, and topiramate is one, but there have other reports that these specific drugs tend to contribute to decreased libido as well as other sexual function. There has been one study that has identified that switching off one of those older medications to lamotrigine, for example, improves libido. So certainly I'd encourage you to discuss this with your doctor. But thank you for bringing it up. It's very important and under discussed topic.
Okay, I have a question for Dr. Peter Carlin. Peter, someone's asked, how can they know if they're at risk of SUDEP? And is there a particular age group that is particularly at risk?
Yeah, the evidence seems that young adults, 20 to 40, are more at risk for SUDEP. Patients who have generalized seizures as opposed to focal seizure are more at risk. But unfortunately, according to the data, everyone can be at risk, but certainly there's much higher risk. Also, if you're slated for surgery or you're being worked up for surgery, that group has a higher risk too because they have worse epilepsy. In general, it correlates with bad epilepsy.
Okay, thank you very much, Peter. Final question for Dr. Gold. Can anxiety contribute to seizures? If you're anxious, are you likely to have more seizures?
Absolutely. So we know that one way, if we want people to have seizures in the epilepsy monitoring unit, is we actually keep them up and we deprive them of sleep, and that makes you more anxious. And we know from our patients that when they are feeling more anxious during periods of stress, they're more likely to have seizures. So I don't say that to scare the group, but just as knowledge and information that having more anxiety makes us more likely to have seizures. And so one thing we can do about that is learn strategies that are helpful for anxiety.
Okay, thank you. I'm sorry we don't have time for more questions, but I just have a few things to say before we go to the breakout groups. I'd like to thank all our presenters today, and we appreciate all of you joining us here today. We'd like to invite all of you to join our virtual Purple Day celebration on Friday, March 26th That will feature artists, stories from people with lived experience, and more. And that will be starting at 3:30, a little earlier. In addition, please send us your feedback about this event and a survey found in a link in the chat box. And this link will also be mailed out after the event. I want to thank the organizers of these webinars and the Purple Day event. Many thanks to Mackenzie, to Jacqueline, to Jarrett from Epilepsy Toronto, Rebecca Wolfley from Eplink, Alex Santos, and Chaim Katz from Kremble and the Ontario Brain Institute for their sponsorship. Okay, now we're going to open a few breakout rooms now. So if there's a speaker you want to chat with, please join a room. I think that we're going to see a list of breakout rooms. Mackenzie, I don't have it. Is it going to come up?
It should be there. All the rooms have been open now. So if the doctors could join their room and the facilitators could join the room that they've been assigned as well. And then everyone else is free to join in the room that they feel most compelled to listen to. And this point, we are no longer broadcasting. So please do turn on your cameras.